everybody. My name is Branden Stokes. Just to give you a little bit about myself, I joined the U.S. Air Force in 2022. So I've currently been serving almost 4 years. I've been a registered respiratory therapist for going on 3 years. And I recently just completed Emerging Leaders program that the ARC had. And I definitely, if you don't know what that is, I would definitely look it up for the individuals who have graduated and this may be their first or second or third year. I definitely implore you to go and check that out because that program offers so many different resources and it allows you to interact with other individuals who are maybe not first year students but who are directors and who are education directors or maybe working in the field that you are actually interested into that can give you a kind of a little guidance on how to get more active in that field, whether that's ECMO, whether that's PEDS, whether that's in the CVICU, or you want to work more with TBI personnel. I would definitely just apply to that program. I definitely know it changed my mindset on being an RT. I would say the knowledge that I had was minimal, but when I went to that conference that just passed that the AARC had in Phoenix, Arizona, my outlook on the respiratory field has definitely changed. So getting into this PowerPoint presentation, and I don't want it to be a death by PowerPoint kind of thing. I want it to be more interactive. So if you have questions, I feel like there is no stupid questions. So if the question seems so basic to you, go ahead and ask because trust me, believe it or not, I was in those same exact shoes. But when I got asked to make this survival guide for first year RTs, it was a no-brainer because my first year, I felt like I was all over the place. I felt like, what was the playbook? Half the time, I felt like I was failing at my job. But after getting along the right mentors and the right peer groups, they pretty much pursued and told me to keep pushing and that this is a journey. Medicine is a journey. And being an RT is a journey. You may not get it at the first try, but as long as you don't give up and you keep pushing forward and learning more, reviewing and actually immersing yourself in the patient care. It doesn't even have to just be just RT work, but even helping the nurse technicians or helping the nurses who are changing patients because it's a team effort. Nobody works for each other, but everybody works together for the betterment of the patient's healthier outcome. All right. So getting started, we are going to start with a topic that I wish I would have known coming as an RT at my first duty station, learning how to master the flow, aka time management. Time management seemed to have been a myth for me because I felt like I was running across the floors, running across different units, trying to locate different patients, trying to locate different treatments, different medications, and the different medical Pyxis access. Figuring out which patient needed my attention more, which patient's treatments could have waited. It just was a conundrum. And I felt like I burnt out so fast because I was pretty much trying to take on the role as Superman. I was pretty much trying to make sure everybody received that upper echelon of care and received great customer service, but I realized that I was doing it backwards. So my biggest quote that I learned the hard way was when everything looks like a priority, nothing is. The most critical skill you can develop is distinguishing between what is urgent, meaning what needs your immediate attention right now, and what is important, considering long-term goals. So you're just getting to your for your first job as an RT, and for those individuals who are still in school, you're doing clinicals, you're just getting there, and they're giving you a list, and there's like 20 patients with 20 different problems. So my first thing would tell you is instead of jumping right in and just pulling those medications and off to do those treatments, prioritize, prioritize, prioritize. Okay, which patient, as in the RT role, you'll learn is circling the drain. So I'm an individual who loves to use stories because I feel like I learned better from telling stories because you just never know when you'll be in that same situation. So if you do end up in that same situation like I was, uh, whatever year you were in, or whether that's first year as an RT working on the floor by yourself with your credentials or in school, just think back to Branden. And he was like, yeah, I remember he told me that funny story. So I had first coming on to my first shift, I was covering the floors. Um, I had one patient in the ICU, but mostly floor treatment, just congestive heart failures and COPD exacerbations, just doing mucus clearance. But my ICU patient was on Mucimist, they were on albuterol, they were on CBT therapy. It just was a lot. So without me thinking and without me actually being cognizant of the kind of level of patient care that ICU patient needed, I immediately decided to start with floors. That was the wrong thing to do because as I was getting report, I was so distracted by how many patients that I had. I was trying to divvy up, okay, what floor am I going to hit first? What people on the floor are going to get those treatments? That I failed to listen to the key term that my counterpart was using, that this individual was having a lot of issues overnight and that this individual had to get taken off the ventilator and had to get bagged because their saturation levels dropped. But I was so busy trying to prioritize and see which patients needed first that it caused me not to listen to what the individual was saying. So, not having listened and having half their information, I decided to start with the floors. Mind you, the ICU is on the fifth floor, the floors are on the second floor. So you can only imagine that hike. And mind you, there's only two elevators that were currently working at that time. So that was pretty much a long run up to the fifth floor. So as I'm in the middle of my treatments, it's probably about 30 minutes into the shift. This is when I was working morning shift. So those two individuals who work morning shift or want to know what the morning shift is like, it's usually 7 a.m. to 7 p.m. and vice versa for the night shift, 7 p.m. to 7 a.m. So it's 7:30 a.m. I'm ticking away. I feel like I'm moving fast. I feel like I'm getting the groove. Like, oh man, this is what being RT is like. I'm so excited until I got that call from a doctor saying, "Hey, this patient needs a breathing treatment immediately." But I'm already in the middle. I'm already in the middle of a treatment with a patient on the floor. So patient safety and patient care, you can't just automatically cut the treatment. And my nurses weren't around because they were still getting a report. So this patient on the ICU was definitely having a bronchospasm, so he needed the breathing treatment. So mind you, I'm new, and this is my first time with a pager. Millennials, we're not really adept or inept on pagers, so I'm pretty much at the patient's bedside, pointing at this device, trying to get it to call somebody, and I'm literally internally, my alarms are blaring. I'm sweating. I don't know what to do. I'm looking around. Mind you, at this point, I'm like, oh my gosh, I let the team down. I'm failing. They're probably going to write me up. They're probably going to do a PSR saying patient neglect. So what I do is pretty much the patient's almost done. The nurse finally comes in. I tell her, hey, I got to run. She was like, what's going on? I was like, I'll be back. I'll explain later. So I run, get up to the fifth floor. I'm pretty much soaking wet, sweating through my scrub top. They're all like, "Hey, are you okay?" I'm like, "I'm fine. What's going on?" I'm here, and I realized this patient had a lot of stuff that needed going on. This patient was mucus plugging, so of course I had to do a saline rinse. I did my suctioning. I gave the patient breathing treatment, and then I realized, oh my gosh, I still have more floor patients to do. By that time, it's almost 9 o'clock because the ICU patient took so much time because, yeah, with his bronchospasm, he's also desatting. So not only am I trying to troubleshoot what's going on, I'm also thinking about, okay, I'm so behind on my charting and on my patient care that I'm ready to throw the day over and start over again tomorrow. So with that saying is pre-shift charting, that instead of just automatically jumping into patient care, first look up who your patients are. Do your first 30 minutes. Okay, this is what I got. Okay, be more strategic at where your patients are located in the hospital. Sometimes it would be very beneficial. The ICU is on the second floor, but apparently all hospitals are not the same. But as you figure out where your patients are, map out what time those treatments are. Understand and learn what those QIDs, Q6s, Q4s, because if you're not caught up on when those treatments are due, you'll end up doing a Q4 treatment for a Q6 person, not only taking away your time, but also you can be overdosing the person with the medication. Um, I like to do this. I like to give little tidbits, little nuggets. The 2 minute rule. If a task takes less than 2 minutes, swapping a dirty nasal cannula or changing a water bottle, do it immediately. There's so many times I can count on my hand where I just made a mental note. I'll do that in about 15 minutes. As I'm giving report and getting off my shift and walking back to my car, that thing that I said I was going to do in 15 minutes reemerges in my mind. And I'm sitting there like, oh my gosh, I literally said I was going to change this person's nasal cannula about 4 hours ago. So if you have the option to do it now, and I get sometimes you just get done doing a round and you're just so exhausted, it'd be best that just do it now so you don't have to worry about later on, because not only are you looking to offer that exceptional customer service and patient care, but you're also helping that next shift so that if something does pop off, or if they do have an incoming trauma, you're looking out for their time so that they can better time management their skills and pretty much prioritize the patients that they need to see. So that's what I call mastering the flow. So moving along, I'm also a person who likes to joke, and this pretty much kind of confirms how I was feeling with that patient overload that I felt with not prioritizing my time. But the thing about it is, what I learned after my first year is keep calm. Everything's going to be fine. Instead of trying to move fast, if somebody says, "Hey, I need this right now," try instead of just sprinting off to do that, not realizing, "Hey, Brandon, you're actually in the middle of patient care right now. How does that patient feel to be cut off in the middle of their treatment, or you explain to them why they're taking this medication to go run off and go do something else for a patient you deem is more worthier?" Not only does that worry the patient, because now they're thinking, "Oh, I'm already here on I'm in a place where I don't want to be at, and this is kind of like the worst day for me." But I'm also hearing that there's a worse day for somebody. So not only do I not feel more calm, I become more anxious, and I become kind of more distrusting in the level of patient care that's being offered to me. So my biggest thing is that, and I tell myself this as an RT today: slow is smooth, smooth is fast. If you have an individual rushing you, a nurse rushing you, saying, "Hey, my meds are due, I need to get this down, this patient needs this now," and you're in the middle of a treatment, do not cut that person's treatment short. Don't shorten that person's patient care. Tell that person, "Hey, I'm in the middle of patient care. Give me 1 second. This treatment's almost over. Please bear patient with me." And it's not looked as you being argumentative or being disrespectful back, but it's you prioritizing the patient, because that's why we're here. We're here to take care of patients and help them get better. So my thing about it is, if you just come back from a code, you're stressed out, you're sweating, you just had to run across the hospital because somebody decided to start desatting, the staff didn't know what to do, and you had to come fix it. Instead of immediately coming right back into that patient's room, take that moment to stop at the door, take that deep breath. Everything is going to be okay. Because what you don't know is patients feed off your energy. So if you come in anxious, if you come in trembling, if you come in irritated because you had to go and do something for a patient that you felt inconvenienced you, patients pick up on that. And when they feel like they don't see the team sync together, that's when they're more likely to question and probably deny the different treatment options that is offered to them, because they see that as a team, as a nurse, a doctor, as an RT, and as a nurse technicians, if we're not on sync, then the patient believes that what we're doing is not correct, or they're not trustworthy of it, because they see us arguing and they don't see us all synced up together. And I would say is also silence feeds anxiety. So if you feel like you're starting to become overwhelmed, you feel like there's just so much that's on you mentally, you just got out of a code, or you experience one of my stories that I just told about having to run across the hospital, pull that older person aside that's in your office, such as your education manager, your manager. Those individuals are there to offer that professional development and let them know, like, "Hey, I feel like I'm all over the place. Do you think there's any tips or better ways?" Or ask those coworkers, because we're all here for each other, and all individuals have been in those same roles that you've been in before. So they actually understand how it feels to be overwhelmed right out the bat. And they can say, "Oh, you should have did this," or they could have offered, "Oh, if you have this patient, I would go see this patient first. This patient denies their treatments because they rather have more sleep and they don't really want to be more in tune with the treatment option. You could have paid that patient at last." One thing I learned is learning from others. That's how we get better. Um, and also protect the physical baseline. You cannot make clear clinical decisions if you are dehydrated. If you have went all day without drinking water, I'm just going to tell you, because I've met so many people in healthcare, That is not okay because dehydration leads to fogginess, it leads to hangriness, and it also leads to headaches. And you can't make the best clinical decisions when you're experiencing all those symptoms. Even during clinicals, as RT students, or even individuals working first year, if you need to step away and go take a sip of coffee or go take a sip of water, go do it. Now, I'm not saying go to Starbucks. I'm not telling you to go get in your car and drive to Starbucks and come back and say, hey, I just need a coffee break. No, I'm not saying that. But if you just need to step in the hallway and just take a breather for like literally 5 minutes and drink water and recollect yourself, do that. All right. And as this meme says, this is fine. I know everything seems busy. I know everything seems on fire, but you are doing a great job. All right. Moving on to the next PowerPoint slide, communicating with confidence. This is one thing that I wish I would have learned right out the gate as a brand new grad on a unit. One thing about the military is usually I know in civilian life, they usually they warm you up on the floors and they move you to the ICUs and they move you to the ED. Well, in the military, we get our certification, we get our certifications and we do upgrade training, but immediately we're put anywhere in the hospital. So, as I like to say, I like to use stories. I remember as a fresh new grad on a critical care ICU, a surgical critical care ICU unit, doctors do rounding in the morning. And as a new grad, I just got this patient. I'm learning about him. And so when they came to rounds, usually as a student, when I was shadowing, the students kind of sat in the back and let the older RTs and the more mature RTs talk with the doctor and give the treatment recommendations. Well, I didn't have that this time. It was me. I was the go-to person. So when I got there, the doctor was hitting me with ABGs. He was like, "Do you think this patient is more alkalotic? What can we do for him if he's more alkalotic on the ventilator? Okay, what treatment options do you think we should do to him? Should we do IPV therapy or should we just focus on suctioning? Do you want to add mucus to it?" And I'm sitting there, I'm like, wow, those sound like so many great options. I'm not sure which one to choose, but what do you think, doctor? And he was like, I'm not the lung expert. You're the lung expert. And I sat there and I was stumbling on my words and I felt like, oh my gosh, I'm not an RT. I can't believe I literally went blank as they were asking these questions. Not only did I just go through RT school, but I literally just passed my ClinSim. So Brandon, you should know this stuff. And I'm here to tell you it's fine. It happens to everybody. Sometimes a person might ask you a question and your mind might go blank for a minute. Instead of saying, I don't know, just say, hey, give me a second. Let me go get that answer for you. Pull one of your coworkers aside, run the scenario down. They'll tell you, you know what you're talking about because as they start to brainstorm with you, all the information will come flooding back. So when you're communicating with confidence, be confident in how you talk to them. You passed that ClinSim, you passed that TMC. You did the work to get through school to be able to get to the place that you're at, and you know what you're talking about. So when you're talking to physicians need objectives, facts quickly. They want to know, okay, where are the ABG settings? Where are the current settings? They don't want to get those roundabout answers like, well, this patient just had a long night, and because the doctors and the team actually have other patients they have to get to. So they can't spend an hour on this one patient because they're doing rounding in the entire ICU. So give them the bare bone facts. And also, as you're giving those bare bone facts and you notice that there's a problem, own your expertise. You are the airway and ventilation specialist. You are the registered respiratory therapist. Remember, you earned that title. You put the work in to get there. So if you know something is not right and you notice that a doctor made an incorrect change on the ventilator or an incorrect amount on the medication dosage and you catch it, you're not hurting their feelings by pointing that out. You're pretty much practicing safe patient care. So if you notice that mistake was made, instead of you kind of being worried about if that person's going to take it the wrong way, no, this is your patient. You are the lung and airway expert. And when it comes to disagreements, be direct about disagreements. If you have clinical concerns, talk to the doctor, or go pull your respiratory supervisor on shift, the shift supervisor, pull them aside and like, hey, I kind of have a question about this. As I learned in school, we don't do this. So, for example, so everybody has interesting stories with doctors. So I had a patient on nitric oxide. As you know, on nitric oxide, you only move down 2 parts per million. Well, this doctor wanted to go from 80 to zero, and I was like, "Whoa, that is a tremendous drop." I don't think that is actually part of our standard operating protocols. We do 2 parts per million, and the doctor didn't want to back down. So instead of taking that hit, because you also have to realize your license is on the line. So if you go along with something, you're also held liable. So instead of going along right then and there, I was like, hey, let me call my shift supervisor who can better explain to you why we have these different SOPs, because going from 80 to 0 parts per million is a humongous drop. So I called my shift supervisor and I told her what's going on. She absolutely disagreed and said, oh no. So she came up there and she talked to the doctor and explained to him why we have SOPs and why that it's inappropriate medically to make that huge drop. And what I did was I advocated for the patient on his behalf. And what do you know? We didn't drop from 80 to 0. We went from 80 to 60, but I'd rather take 80 to 60 than a 80 to 0 drop. All right. So just to caveat that, be confident who you are, be confident in your skills because you did the work to get to where you are. And be confident when you disagree. And it's okay. It's okay to ask the doctor, okay, what are you thinking, so that you all can get on the same page. All right. Moving to the next one, also communicating with confidence. When you're translating the machinery, you're in school, you learn so many different modes of mechanical ventilation. You're learning about tidal volume, you're learning about PEEP, you're learning about driving pressure. So when it comes to explaining these things to patients, sometimes the academic jargon will automatically pop out. And sometimes the patient will nod the patient's family and the patient will nod their head along as if they agree, but usually 9 times out of 10, they don't understand what you just said. They feel like you just spoke a foreign language. But what they really do appreciate is if you can just break it down into a more baby or a more acceptable kind of way of speaking. For example, most of the patients that you get who are having first time exacerbations for COPD or who are having asthmatic attacks are more worried and scared. And they're seeing all these machines come in and they're like, okay, what is this doing? I don't know what's going on. And you, right then and there in that moment, you can explain to them, okay, this is what this does. Now, you don't have to go in detail, but you can tell them in a roundabout way of kind of what this does and how this can make that patient feel better so that they're put more at ease and that they know that their loved one is being taken care of better. Now, you also want to project calm commands. A patient's coming. When somebody can't breathe, that is literally one of the most scariest things. It's panic. They're terrified. They're panicky. They're not listening, and you might see some of your coworkers or might see some of the staff members get flustered and annoyed because they feel like the patient is just ignoring them or fighting against what they're saying. And it's not that they're fighting against what they're saying. They're in such much of a flight or fight mode that they just can't comprehend what you're saying because pretty much they're trying to survive. Not being able to breathe is not a good feeling, but that's where you come in as a lung airway expert and you project that calmness. So, for example, I had an individual who had a COPD exacerbation. The patient was breathing extremely fast. They were pursed lip breathing. They were scared. They were like, I don't know what to do. I'm scared. I've never experienced this. And I really just put my hand on his shoulder and I said, hey, you're all right. We're here to take care of you. Breathe with the machine. I even went over breathing commands when I said breathe in and breathe out. And the more I did that, it might have took about 10 minutes, and he finally synced with the BiPAP machine, and he was able to go along with the treatment. He was able to calm himself down. He was able to not blow off so much CO2. And right then and there, in about 40 minutes, we flipped his acid base balance, and we were able to prevent him from almost being intubated and his loved one having to see that traumatic experience. And one thing that A lot of people are going to ask you as an RT, why are you doing that? Why do I need this? And our quick response is, well, you need this because this is what you need. And if you don't do this, you're going to either be intubated or you're not going to be feeling so well in a couple of hours. Explain the why. Why are you doing this? This person has this specific pathology, or this person needs some humidity added to the nasal cannula. You're not just adding a bunch of stuff. You got to remember, these patients are in this these patients can be in ICU, they can be on the floor, but they're being visited by so many individuals. They're being visited by the floor nurse, they're being visited by interns or residents or a full team of doctors, and then you're coming and they're adding something in, and they just think, oh my gosh, I'm just receiving so many things, and nobody's explaining to me why I need this or why I'm going through this or what's next. You're kind of like the bridge builder, like, hey, this is why, what's going on. Now, I'm not saying step into doctor role, I'm not saying step into nursing role, but know your why. Know why this patient's receiving this. Okay. This patient's been on a nasal cannula. He can't get off a nasal cannula, but he has to be on a nasal cannula 24/7. Eventually his nasal pairs, his nasal passages are going to get dry. Say, hey, sir, I'm just adding this humidifier just to kind of give you a little bit of moisture. I know your nose has kind of been feeling dry, but this is going to help it, loosen up that mucus, but also make it more comfortable for it to wear. And when you explain that why, they feel like, okay, this person who's taking care of me considers my feelings. All right. So also, when it comes to teaching individuals how to use inhalers or how to use incentive spirometry, we're not just dropping the things off and automatically expecting them to use them. Some individuals have never seen an inhaler, and you think, oh, they're like, yeah, I know how to. I know how to do it, use an inhaler. I use it at home, or I watch my kids at home use it. And you're like, okay, can you show me how you use it? And it's like, okay, well, they squirt it, and then they tell the patient, okay, breathe in the air to breathe in the medication. I'm like, whoa, that is not how to properly use that, and how are you using it is ineffective. Now when you begin to realize that, when you ask them to help them teach you how to use an inhaler, you begin to realize this is why you're receiving so many asthma attacks, because you're not properly getting the medication. So if you have individuals who you wonder if they properly know how to use it, it's okay. Hey, can you show me how you use that? So just to make sure, so we can know where the issue is, so that we can better serve you and better help you in patient care. All right. And that is communicating confidence, staying calm in emergencies. Lord knows how many times I have internally freaked out. On the outside, I'm like, yeah, everything is going all right. But going back to that meme where it's the dog sitting in the chair and the room's on fire was me. My first code blue. Boy, everybody has stories. My first code blue was with an 80-year-old patient. She had an aortic dissection. Mind you, when you do CPR for the first time, you do it on mannequins. You don't do it on real live human beings. So mind you, this 80-year-old woman, she's like skin and bones. She has a towel wrapped around her mouth. She's intubated, and they have a lot of units of blood pumping into her because she's dissected. And now it's my turn to do CPR. I froze. They asked me, are you on next? I shook my head and kind of backed away. And that, after I got off shift and I went home, I beat myself up. And instead of building myself up, I tore myself down. I questioned if I was meant for patient care. I thought I knew what to do. I'm not good at my job. I'm not meant for this. Maybe I should go back. Everybody at the hospital is going to laugh at me. My coworkers are not going to trust me no more. And it's safe to say, take a deep breath and be calm. It's okay, because everybody has been in those shoes before, and everybody has understood what it means to be in those moments, those critical moments where it's just so much comes flooding at you. The room is packed, it gets hot. You go from a real big room to a short room. Everybody's clambering on top of each other. Somebody's yelling RT. I forgot I was RT, but I was at the head of the bed and bagging. They were asking me, are you RT? I said, yes, I am. So there's so much going on at once. You just don't know what to do. And if you freeze, 9 times out of 10, you'll have coworkers that'll also come to that code with you and run to that code. Look at them, say, and be honest, I don't got this. and step aside and let them take care of that patient, but also watch what they do. The thing about trying again is instead of falling down and staying down, get back up and try again. So staying calm in emergencies, fall back on that tactical disciplines. I know in school or in first year, each hospital has different protocols or who shows up to the different codes and stuff. Learn those protocols, learn your SOPs, because usually when emergency situations are going on, people kind of tend to rely on instinct instead of fact. And sometimes those instincts kind of venture out of SOPs and they kind of get into the illegal territory. So you want to be that person who starts to see that people start to deviate from the proper roles and proper procedures during CPR. You want to be that person that speaks with confidence. Hey, that's not according to SOPs, according to the hospital. Let's please do SOPs. That's not you being a know-it-all. That's you advocating for the patient to ensure that we're offering patient safety care. And also, when staying calm in emergencies, you're going being in the ER or being in ICUs, you're going to see traumatizing things. I'm not saying that's the entirety of the respiratory field because there's so many different departments and so many different clinics that you can work in as an RT. But when you come across these issues or when you come across these traumatizing events, focus strictly and focus strictly on what's important at hand. The emotions can come last after you pretty much get that patient situated. But right now, this patient needs you to save their lives. You want to be focused on this patient, not how everybody's feeling, or not at this patient's age, or not at this patient you may know, or a patient or a family friend that you know of. I would say focus strictly on the mechanical needs, the airway pateness, oxygenation, and ventilation. Focus on offering that exceptional patient care. And also, when you're in codes, you'll have people that will try to bump you out of the way of the head of the bed. And it's not a position of authority, but you are the lung and airway expert. If you remember anything out of this, remember who you are, but also remember that you're the expert and that you're the expert and that you got that certification that makes you the expert. So you take the decisive ownership and claim the airway. For example, sometimes as residents, who are learning how to become fully credentialed doctors, this might be their first time intubating. And you notice, okay, we've saturated this person's lungs with oxygen, but this resident has taken about 4 times to try to intubate. And you notice this patient starting to desat, but you also notice that we're starting to get blood also in the suction because now we're causing trauma to this patient's airway. And now it's going to become even more difficult to properly ventilate this patient because now it's going to be hard to take put a tube in his trachea because his airways are swollen just from edema that we've caused. So if you notice this person is struggling, say, hey, sir, do you want me to step in? Because we need to make sure this patient gets on this ventilation quick. We've sedated this patient and we paralyzed him. He's not breathing. His CO2 is building up. I know you want to get your intubation on the first try. There'll be other tries, but I need to step in and take over, or we need to call somebody who can come and ensure that this patient gets properly intubated because we do not have time to cause this person to have a swollen airway, but also hemorrhage in his airway. And my biggest thing is utilize closed loop communication. There is so much stuff and so many things going on in a code blue that you might mention something to somebody. Hey, I need a capnography, and the person say, "Okay, I get it." And then you're waiting for about 40 minutes, and they're like, "Hey, do we got color change on the tube?" And you told this person, "Hey, I told you 40 minutes ago, give me a capnography," but this person is so task saturated, hearing other demands and hearing other people scream for stuff, scream for units of blood, scream for epinephrine, scream for more sedation, that they completely forgot what you asked for. So utilize that closed loop. Have them look directly at you. I need a capnography right now so that they can grab that for you so that they won't forget. Believe it or not, this happens a lot, probably 8 out of 10 in very dire situations. So when it comes to code blues and emergencies, stay calm. You know, how I got used to it and how I got over freezing up, I kind of got just thrown in there like, no, you're going to do CPR today. So I got over that fear. I just didn't want to hear the ribs popping like Rice Krispies, but eventually you get used to it. They say if you're not breaking ribs, you're not doing CPR right. But immerse yourselves. The more you immerse yourselves into these codes, the more second nature comes to you and the less anxious you begin to feel. Last but not least, prioritize self care. Our job is physically demanding. A lot of people are going to require a lot out of you. Patients are going to require a lot of you. Family members are going to require a lot of you because they expect you right when you get off to come and give those family needs, such as the cooking, such as the cleaning, such as the child care, such as the love, such as the parenting. So many people expect so much out of you, but one person that you need to listen to the most is yourself. You can't, if you're not healthy, your patient care will not be healthy. So, last but not least, my last story, as a first year new grad student, I took on that role. I took on that Superman complex. I didn't realize I burnt myself out. I didn't realize, okay, I'm working night shift now. All right, I'm just going to go to sleep, wake up, go to work, go to sleep, wake up, go to work, go to sleep, wake up, go to work. I didn't realize I was isolating myself. I was becoming so work focused and so work minded that I stopped doing the things that I liked, that brought me joy and that brought me fulfillment. That I began to know to take a toll on my patient care. I began to miss things. I began to mischart. I was tired. I was sluggish. I was moody. And life was, as we all know, life be life and sometimes. So I like to do the self care for helpers continuum, physical, social. Get out. If you like gardening, go gardening. If you like to visit the botanical garden, if you love to visit botanical, if you're in Texas, please go to botanical gardens. Very beautiful. I love flowers. But if you like skating, if you like reading books, prioritize your self care because if you do not prioritize yourself, you cannot properly and effectively prioritize your patients. And one thing that we see so many healthcare workers suffer from is sleep deprivation. Most people think, oh, I only need 4 or 5 hours of sleep and I'm good. Eventually, that person begins to break down. And as the person begins to break down, that person can begin to make constant mistakes that not only will cost them their job, but also cost their license that they worked so hard for because you work really hard for your license. But also it causes their peace of mind to go out the window, but it could potentially cost that patient's life. And there has been instances where there has been individuals that have cost patients' life. So instead of getting out that far, if you notice you're burning out and you have some time off on your you have some leave built up, take that leave, take that time off, recuperate because you can't be a better RT if you're not a better person for yourself. So as we go to protecting sleep and routine, establish that strict sleep hygiene to manage the physical shock of transitioning 12-hour shifts. Because those 12-hour shifts be 12-hour shifting. I'm not gonna lie to you. All right. But also maintain physical readiness. I'm in the military. We're required to maintain our physical fitness, but getting outside and walking in the sunlight, absorbing that sunlight, just being outside, being in nature, I noticed that helps me de-stress and that helps me feel better as a person, but also moving my body doesn't allow me to be stagnant and allows me to release the dopamine just to give me that relaxation feeling. And also establish a post shift boundary. You know, leaving work, sometimes it's hard to leave work. You have those patients on your mind. You're thinking, oh, I wish I could have made this decision. I wish I could have did that. Why did I put my foot in my mouth and talk about this mode of mechanical ventilation because it sounded like I didn't know what I was talking about? That was that day. That was that shift. Leave it in the parking garage. Turn on some jazz, turn on some nice music, let the windows down, unwind on that car ride home because when you get through that front door, whoever's waiting at home is expecting that person that they first loved before they became an RT. Learn to have that fine boundary. And last but not least, keep those long term career goals in sight to maintain perspective. Why did you become an RT? You wanted to become an RT to do transport. You wanted to become RT to allow it to lead towards other aspiring goals, whether you wanted to work in as RT, to become a PA, to become a physician, to become a nurse, to become a CRNA, or to become a certified perfusionist. Always keep in mind your why. why you decided to become an RT in the first place, why you put yourself through the schooling, and why you are trying to save people's lives. Most people think about when it comes to saving people's lives, they think it's only referring to a doctor. No, you're a part of the team too. You're helping save lives, whether it's that life saving albuterol for a broken leg, you're saving that person's life in that moment. But each and everything you do matters. And as an RT and as a first year RT or as an RT, as a person in school who's almost done with RT school, what you're doing matters. I know you don't see the outcome right now, but if you keep up that determination, if you keep up that motivation, you'll definitely become the successful RT that you envision in your dreams. And that is my first year survival guide as an RT. Thank you so much.